Okay, good afternoon. Thank you all for being here, and especially for our patient panel this morning. Your words were very powerful, and thank you for being vulnerable among this community. I think we are all learning a lot from each other today. And on the theme and on the line of treatment options, Dr. Galore and Dr. Jacobs, we've alluded to the fact that there are many treatment options, and we need to make sure we're using the right one to treat the right type of disease. And so for all of our industry reps today, they all make different kinds of treatments for different parts of the breakdown on the ocular surface. And all of them will help some patients. And not one product is going to help every single person. And so on that line, I'm going to talk about one treatment option that comes typically later in the stages to treat patients with moderate and severe dry eye. But before I do so, I'm curious, how many people in the audience here wear scleral lenses? Okay, so we have a couple people here. And so I'm going to get into that here. This is what scleral lenses look like on the ocular surface. They're large, rigid plastic devices that vault over the cornea and the edge of the cornea, which we call the limbus, and sit on the white part of the eye, which we call the sclera, and there's a layer of conjunctiva that overlies that. And in this cross-section, you can see that there's the lens, and then there's a fluid reservoir space, and then there's the cornea if you look beyond that. A question that I get a lot of the time is, how long have these scleral lenses been around? And people think that they just popped up within the last 5 years. But actually, they were the first concept of contact lenses. People thought about this and tried to design them in the 1800s, but they didn't have the materials and technology for it to be successful. In the 40s, we went smaller because they couldn't get the big ones and oxygen and good health, so they developed hard contact lenses, gas-permeable lenses that are great for vision correction. Then we had soft lenses, which were so much more comfortable and easy to produce. But then in the 1990s, and around the time that Dr. Jacobs was at Boston site, there was a resurgence of scleral lenses because eye care providers realized the great potential they had in not only helping to correct vision, but also treating ocular surface disease. Then we had hybrid lenses with soft and rigid joint together or on top of each other with piggyback lenses. And now in the last 25 years, we've been working with industry and scientists to make better improvements in all kinds of our contact lens designs. Here are some scleral lenses from the 60s that a patient gifted to me. He said that a doctor fit these for him, and you can even see that they're not perfectly spherical. They were based off of a mold, even back in the 60s, and you see little holes which are called fenestrations. But he said when he wore them, they felt really hot, and then it just didn't work. My guess is that they were made out of a plastic with zero oxygen permeability, likely PMMA, but I'm not sure. And they just didn't work physiologically with the cornea. So scleral lenses, here's the diagram that came from Boston site. The lens overlies the ocular surface, and it's this fluid reservoir that provides constant lubrication to help patients with corneal disease or dry eye. And the fluid can help the outer layer of the eye regenerate. So lots of times when you see breakdown in the epithelium, you want to put like a bandage on, and that's essentially, this lens can act like a bandage. The plastic itself also acts like a shield to protect your eye from the elements, the wind, and a lot of the irritation potentially from the friction of your eyelid blinking constantly. Also, in the last 20 years, we've seen a huge interest and demand in these scleral lenses. We have the Global Specialty Lens Symposium, which occurs every year in January, where experts from around the world come and discuss and talk about their challenges and what worked for them and how to be better. We have the Scleral Lens Education Society with a lot of resources, not only for doctors, students, but also patients. And we also have My Big Fat Scleral Lens. How many of you are involved in the Facebook page? There's a large community with a lot of discussion about scleral lenses. We even have the recent publication of my Big Fat Scleral Lens Patient Handbook, which Rebecca really developed almost entirely on her own. So I encourage those of you who are interested in scleral lenses or even wear them, this handbook is a really wonderful resource. I also want to make a note that scleral lenses are not all the same. And if you go to 5 different scleral lens providers, they will likely fit you with 5 different types of lenses. They vary in the diameters. They can be as small as 15 diameters. They can go as large as 23 millimeters. And that affects the way the curves are. The smaller you are, the more spherical you can go. But as you move further out on the eye, the shape changes more and it becomes more of what we call toric or asymmetric, which makes fitting larger lenses more challenging because you have to get the right curvature. There are modifications that include vaults to go over bumps on the eye like pinguecula, or if you've had glaucoma surgery, channels to enhance oxygen. There are different materials that impact the oxygen permeability and even coatings to help with wetting. There is something called tangible hydropeg that makes the lens really slippery and can aid in improving comfort for the right patient. There are also now image and impression-based designs. I have a profilometer in my clinic, but I started fitting scleral lenses really without any technology, just using trial lens sets, and I still find that that has worked really well for me. And now we have impression molded designs where you use this blue goo and you put it on the eye and it comes out with a mold that you send to a lab that can make a lens for that eye shape. However, keep in mind that our eyes are not like a solid rock. When you move your eyes around, your muscles move. When your eyes blink, it moves. And also the conjunctival tissue is soft and it does settle. So it's not that one impression-based lens, oh, if it works well, why don't you do it for everyone? It doesn't always work for everybody. And there's also different doctors, consultants, fitting guides, and price points. So here on the topic of dry eye, scleral lenses definitely play a role in protecting and soothing the ocular surface, but they also help to improve vision in a different category of patients with scarring or irregular shapes where they can't wear glasses or contacts. Some people wear scleral lenses for both, for improved vision and improved comfort. We have to be aware of risks in our monocular patients. There is risk for wearing any type of contact lens, whether it's a gas permeable, a soft lens, or a scleral lens. Hygiene and compliance is very important. And I'll also say that, achieving initial good vision or comfort on your first try with these lenses doesn't always equate to you being a good candidate. There are many challenges over time that may complicate lens wear. So here are the main 2 categories for indications. One is irregular corneas. Maybe you've had surgery and it changed the contour of your eye, or you have something called keratoconus or pellucid marginal degeneration. And then there are also the ocular surface disease category, whether you have scarring or inflammation due to an infection, or you have a systemic disease like Sjogren's syndrome or graft versus host disease, or a rheumatological condition that is causing inflammation in your body and also your eyes. So on the irregular cornea side, we definitely don't jump to these lenses as the first line vision treatment. We'll go through glasses, soft lenses, and even GPs before getting to the more complicated scleral lenses. There are also many different contact lens types. I don't want to get the idea across that scleral lenses are the only lens and the best lens for everybody. Some people may benefit from the soft lenses. There are custom soft lenses as well. GPs, hybrid lenses on the top, on the left side, where there's a hard lens that is bonded to a soft lens that is ideally supposed to enhance comfort and improve optical properties. Sometimes they're a little bit thick, and so they can definitely feel more awareness than just a typical soft lens. And then we have our scleral lenses on the right. So we know that it helps with vision. Here are some pictures of really ectatic eyes, or those who have had RK or a transplant where, they can't see with glasses, so they definitely help with vision rehabilitation. And then here are some conditions associated with ocular surface disease. Maybe some of you in here might have to deal with one of these systemic conditions or an eyelid anatomy issue like exposure, whether it's due to acoustic neuroma, maybe you had a tumor removed that severed your nerve that's related to the eyelid closure, or you've had Bell's palsy, some type of eyelid cancer where they had to remove a part of your eyelid. There are also complications from cancer treatment or radiation, effects of viral infections on the eye, and also after surgery. And then here are just some images of what the ocular surface looks like, what I look at through the slit lamp using that sodium fluorescein. And again, as Dr. Gloria mentioned, we look at all aspects of the eye. I always start with having my patients close their eyes. I look for closure. I look at the lashes. I look at the base of the eyelashes, looking for inflammation, Demodex, or meibomian gland challenges. So we've kind of said this point multiple times today already, but it's important to understand the cause of your ocular surface disease or dry eye. It's not all the same, and that one code that we all bill, when we see that patient, it doesn't mean that the patient is experiencing the same thing or presenting the same way. We must understand when we're offering a treatment, the role that plays for our patients, consider appropriate orders for treatments. The DEWS 2 publication had a staged approach from more basic to more advanced therapies. The DEWS 3 report came out 2 months ago. I haven't read through all thousands of pages in the 3 reports, and I'm not sure I'll get to that. Have you? Anybody? Well, the DEWS 3 report did come out, and I'm excited to learn more about that from people who have summarized it for me. But through reports that we have had since 2007, we know also that scleral lenses can't be prescribed in isolation. So many of my patients are also doing hot compresses, lid hygiene, using tools, wearing moisture chamber goggles, using different kinds of tears or eye drops, different immunomodulators that maybe they've tried different ones. So we need to consider that we're not just fitting an eye shape here, and we want to also be cautious of just getting an image or a scan and ordering that lens and popping it on and thinking you've cured the patient, because that's not the case. There are some patients that even if you get the most precise fit, they just can't tolerate scleral lenses due to the sensitivity in their eye. Maybe the pain in the cornea, it's not being addressed adequately, or the friction from the eyelid and the lens edge itself. So scleral lenses are not easy to handle. They're tricky to apply. We spend at least an hour to 2 hours with every patient training them in my clinic. I have a very well-trained technician. I actually did trainings for 5 years in my clinic before my service agreed to hire more help for me. So I understand the challenges emotionally, physically, the cost involved, and finding your solutions when there are back orders or recalls. There are all kinds of tools. These things cost money and time and effort to purchase and find. There are stands. This I really love here because we have to remember we're treating patients of all ages. And there is a company present here today that came up with this adorable little Lensy plushie, which is the first scleral lens plushie. And I do have this in my office. And for some of my younger patients, I'm like, do you want to hold Lensy? Oftentimes they're freaked out anyway to be in my clinic, so it doesn't make as much of a difference. But I also have these great, it comes with a little booklet that I've given to some of them. So for scleral lens wearers that struggle with application, maybe because your eyes are in too much pain to pry it open, to shove a big lens in, or because you can't see, there are stands, there are lights to help with fixation that come at different sizes and heights to help you, and just know that everybody's experience is different and what they need for success. This is another great tool that I use. It's just you put it on the table. There's a little light so that when patients can't see, at least they have a fixation light that they can look down in so they know where their eye is going. So obviously this is a lot. And I'm not just randomly going around fitting every patient that comes into my clinic. If a patient has never tried any different dry eye treatments, I will never start with the scleral lens. I will always offer topical medications, more, easier options to not disrupt their lifestyle as much. If they've tried topical medications and plugs and they've been through that process and all the tears and ointments are not helping still, that's when we move on to scleral lenses. Here's another, this is a close-up of how the light is applied to the hole on this plunger. Hygiene is so important, not only for scleral lens wearing patients, but for all of our dry eye patients. When you have staining on the cornea, you're more susceptible to developing infections because the bacteria or virus can now seep into your corneal tissue more easily when there's rubbing or a break or a rough surface. But with scleral lens wearers, we want to make sure we're using the right solutions to clean and disinfect and fill the lenses only with non-preserved sterile saline, otherwise it will lead to problems. So again, with contact lens wear, scleral lens wear, there's always a risk for complications, ulcers, and infections. We know that the scleral lenses are protective and act as a barrier and help to relieve symptoms quite dramatically. I have done the research, I have administered the surveys that look at symptoms, and I have seen improvements in patients who wear scleral lenses. There's a role in healing abrasions that don't heal on their own as expected. It has also been shown to be a mechanism for even drug delivery, using different medications to kind of permeate and penetrate the cornea for longer periods of time. But we have to be cautious and know that it doesn't come without risks, and we have to be vigilant in our daily care as well. So scleral lenses, although they're not for everybody, especially those who have issues with oxygen, hypoxia, patients who have had a cornea graft or Fuchs dystrophy, and those with highly bumpy eye shapes, it makes the fitting more challenging as well. Now with some of our image-guided and impression-based technologies, it's been very helpful. There's also a daily cost and effort and time that goes into managing these devices, and sometimes patients may need assistance from a family member or a caretaker. There's also fitting challenges with films that develop and midday fogging that requires sometimes maintenance during the day. And what about age? I'm just on the cusp of trying to publish a paper showing that age really isn't a factor when considering whether your patient can be a candidate. I have fit patients very young. I think when I was at Boston site, when we were training, I was working with one of my colleagues, Dr. Lynette Johns, and we were fitting a 1-year-old with familial dysautonomia, and they had traveled, I think, from England for care. I've also treated patients who are 100 years old who have keratoconus and still able to wear the lenses. I do not believe that age is something that can prevent you from wearing lenses. It's really the motivation. So in summary, scleral lenses are an excellent treatment option for the right patient with irregular corneas and ocular surface disease, but you need to make sure that you've done the right test and gone through the process to make sure you're a good candidate. These are medical devices and can contribute to complications if not worn appropriately. And also other adjunct therapies may definitely still be needed. A lot of my patients still rely on their artificial tears, lid hygiene products, and once in a while they will have procedures done to enhance their overall symptoms and experience. So thank you very much for your attention. Rebecca.